Welcome, everybody. We're glad that you are joining us this afternoon, and welcome to today's webinar titled Parent Support Services, Models of Service Delivery. My name is Melissa Pearson, and I am the project coordinator of the family-run Executive Directors Leadership Association, otherwise known as FREDLA, and this webinar today is being provided by the TA Network. The TA Network is a partnership with 3 other universities and 7 organizations you see listed on this slide. The TA Network provides technical assistance to the Child, Adolescent, and Family Branch of Sampson Center for Mental Health Services and to grantees of the Children's Mental Health Initiative across the nation to support states and communities to expand and sustain their systems of care for children, youth, young adults, and their families. The Family-Run Executive Directors Leadership Association, or FREDLA's mission, is to strengthen the leadership and organizational capacity of family-run organizations who are focused on the well-being of children and youth with mental health, emotional, or behavioral challenges and their families. Started in 2013 by 16 statewide family network directors, FREDLA was fortunate enough to be asked to partner with the TA Network to support System of Care grantees. And we provide technical assistance to System of Care grantees and family-run organizations in the form of webinars, topic-specific consultation, site visits, resource materials, leadership camps, and much more. So we are really excited that you have chosen to join us today to hear about the different models of parent peer support. As most of you know, family-run organizations have been providing parent-to-parent support services for over 25 years. What's recently changed is the way these services are funded, the qualifications, training, and certification of those providing the services, and the organizations and agencies who are taking advantage of this support for the families they work with. A joint bulletin by CMS and SAMHSA was issued on May 7, 2013, titled Coverage of Behavioral Health Services for Children, Youth, and Young Adults with Significant Mental Health Conditions, outlining what parent peer support services are and allowing states to utilize Medicaid funding to make these services more available. Since then, many states have begun working to expand access of parent peer support services for families raising children with emotional, behavioral, and mental health care needs. In May of 2014, FREDLA conducted a survey of family organizations across the country to better understand the state of parent-to-parent peer support services being delivered through those family organizations. The study revealed some interesting results. Of the 25 family-run organizations who completed the full survey, here is what they told us. 1, most of the organizations were in the process of developing a parent-to-parent support service model. However, many were struggling with issues of implementation. 2, most of the organizations were using a state-specific training certification model. However, those using a state-based model were aligning it with the national certification initiative through the National Federation. 3, while many of the states developed language in their Medicaid state plans and/or waiver applications, few of those states developed language that specified parent peer support. Typically, it was a general peer support definition. And 4th, most of the states chose a separate training or certification model for parent peer support providers than that of the adult peer support providers. Through our work over this past year, we have clearly seen that while parent peer support services are widely recognized as a crucial service to families raising children and youth with behavioral health care needs, there is still much needing to be done about how family-run organizations structure, fund, implement, and assess the parent-to-parent support services they provide. While most states are in the process of developing a parent-to-parent support program model, few of the family-run organizations who provide these services are able to directly bill Medicaid as a way to fund them. There are several reasons for this. However, many of them are finding it extremely difficult to meet the state's requirements to be a Medicaid provider organization. So for these reasons and many others, we are so fortunate today to have 3 incredibly talented presenters with us. During today's webinar, we will hear from Ruth Fox of the Allegheny Family Network, Darren Harris from the Ekaya Youth Project, and Paul Cornels from the Alaska Youth and Family Network. All three of them have developed different models of providing parent-to-parent support services for families. The thing that is the same is that they all offer a high-quality parent-to-parent support service for families that is producing powerful, positive outcomes for families and the systems they are involved in. As we go through each of their models, we will explore the following key areas: program models, referral process, funding mechanisms, outcomes, and cross-agency collaboration. Before we hear from them, let's spend just a few minutes on each of these areas as it relates to conceptualizing what your parent-to-parent support model can be. When developing a parent-to-parent support model, here are a few things for consideration. The first is staff qualifications. You will need to determine, other than lived experience, if there are additional qualifications you want to require for the persons providing parent-to-parent support. For example, some communities look for family members who are further along in their journey, have demonstrated ability to communicate effectively with service providers, and are able to separate their own experiences from those of the families they support. A second consideration is training and/or certification. Will the parent-to-parent support providers need to be certified to provide the support service in your state or community? And if so, who will do the certification and/or training? When we conducted our survey in May of 2014, over 85% of the family organizations responding indicated they plan to use a state-based training and certification model. Another area for consideration is supervision. If you use Medicaid funding, will you be required to have a specific type of supervision, and who will provide that supervision? The location. Where will the parent-to-parent support providers be located? If the family-run organization is the entity providing the parent-to-parent support providers, will they be located at the family organization, or maybe at the child serving agency, or somewhere else? As you can see, there is a wide range of infrastructure models for parent-to-parent support. This slide demonstrates some of the options for employment, supervision, training, certification, and location. You'll see on one end the family organization model, where the family organization employs, supervises, trains, certifies, and houses the parent support provider. On the other end, the government agency employs, supervises, trains, certifies, and houses the parent support provider. What is key to remember is that as you develop your model, you want to be sure that it suits you, your organization, your community, and the families that you will be supporting. Another area to consider is the referral process. Some models are structured in a way that allows families to self-refer, while others require the funding source to refer families for parent-to-parent support services. The other question is whether families are able to access parent-to-parent support at the initial point of contact with the system, or whether they have to be at a certain level of system involvement to be eligible for parent-to-parent support. Another area, parent-to-parent support can include a variety of activities, including system-specific activities such as attending juvenile court hearings or special education meetings with the family. One of the main components of parent-to-parent support is that the provider have lived experience, that the support be community-based and family-driven, and that it meets the needs of the specific family receiving it. And last but not least, there is the funding. Funding can be a determining factor when it comes to how you design your model. For example, if you use Medicaid, the Medicaid manual in your state may set specific guidelines and qualifications for training, supervision, and certification requirements. Medicaid can provide a sustainable source of funding. However, it comes with a specific set of parameters that must be filled and can sometimes create significant burden for a family-run organization. On the other hand, if you utilize funding from a foundation, They may allow the organization full discretion to design the program model. The drawback to this could be that this funding may be time limited, it could be one-time only funding, or it may not be something you could apply for again. So in the end, it is important to diversify your funding and seek funding sources that are sustainable. Now I'm going to turn it over to Ruth Fox from the Allegheny Family Network in Pennsylvania.
Good afternoon, everybody. I'm really happy to be here and to be able to just share a little bit about what's happening in Allegheny County, really Pittsburgh, Pennsylvania. So I just want to start by just giving you a little history about how our organization was formed. There was about 6 parents, family members, who had children with behavioral issues and were not very pleased with navigating the systems in Allegheny County. And so they come together and they said, you know, we have to do something for families. And from those 6 parents, AFN, or Allegheny Family Network, was incorporated in 2004. We received our first grant, contract grant, in 2007 from the System of Care. It was a Starting Early Together grant, and we supplied the family support partners for that team. So that was kind of the very beginning of Allegheny Family Network, and since then we were probably had 5 employees then. We now have 30 employees, and we're serving approximately 300 to 350 families a month with one-on-one support, and probably connecting with about 550 a month through support groups and different things like that. I also wanted to just let everybody know that Allegheny Family Network is the state chapter for the Federation of Families for Children's Mental Health in Pennsylvania, and I'm also a board member of Fredland, very honored to be that. So Allegheny Family Network's mission statement is to support and partner with families raising children who have emotional and mental health needs in order to improve their quality of life. And so as we go through the slides, we're going to talk about the different program models that we have and how we help families here in Allegheny County. So we have, we call it the AFN chat line, and it really is just a confidential support line. It's not a crisis line. If parents call in crisis, we have a crisis center that we refer them to. But this is just a parent having a bad day who needs some conversation from another parent. And through the chat line, we get some of our self-referrals. And so, you know, a family calls in, is having a problem, talks to another parent that's an employee here at AFN, and, you know, ends up wanting some one-on-one support, or maybe just some resources or some other things. So the chat line does many different things, and what we've found in Allegheny County, and this might happen for other folks, is this chat line does not get it utilized as much as we initially thought it would, because Allegheny County has like tons of lines that people can call. So you might want to look at what's going on in your community to see how effective those kind of connections would be for parents. The other thing we have is we have a parent educator organizer in the organization, and she really works with parents and does all those things that we do with parents, like focus groups. She organizes all the family support groups. She puts together our parent advisory board. That's a very important piece of Allegheny Family Network, and we depend on the parent advisory board to look over everything we're doing to, you know, make sure we remain very family friendly and family focused. and that we hear families' voice and choice in everything that we do. She also is a trainer. She trains our parents in all the different curriculums that we offer to them. And so this is a real important part of what we do. She also organizes all of our events. We have like a mental health expo in the summer. We have an annual cookout for families. She organizes all of those things as well. And then I'm just going to talk to you about several of the programs we have real quickly. Our first program is what we call our Allegheny County Community Program. And we have 6 family support partners that work in that program. And they do one-on-one support with families in their home, but we always work together with other providers. So there may be other providers in the home, like home-based providers or whatever the family may be involved with. It might be service coordination, other things. What we do is if we get a referral to work with a family, sometimes those referrals come from service coordinators because they're struggling to make a good connection with the family. When we go in, we always let the family know that we're going to be working with the service coordinator and be a team. So we don't go in and try to, do our own thing. If there's other providers in there, we work directly with them as well. Then we have a program we call it the Joint Planning Team. It really is a high-fidelity wraparound program, and it's supporting families that are at the top 2% of mental health users of mental health services in Allegheny County. And we do that in partnership, again, with 2 other providers in Allegheny County, and they provide the facilitator for the team. Allegheny Family Network provides the family support partner, and then the county has a youth support component to it, and they provide the youth support partner for that team. And so there's 3 people on the team, all coming from different organizations, but we've really made it work really well for families. And as a family organization, I have to say that we really like this model of providing families services. However, it is a costly model, and so getting funding for it is interesting. And then we have a program called Children, Youth, and Families. That's our CYF program, and this is involvement with child welfare. And we've been really doing more and more work with the CYF program here in Allegheny County. We have a court program, and that's supporting families in CYF court with prep and debriefing, and following up with support if they would like to continue family support. And what we've seen is that families are getting their children back, families are getting their children not taken from them, and we just actually did a survey that shows that we surveyed the court staff to see what they think of the family support being in the courtroom, and it was all very, very positive. So we're looking to expand that program. Also, we do a foster care program where we're working and supporting foster parents who are caring for adolescents. And this is a program that's pretty new for us, but we're getting excited. We've got about 20 families involved right now, and so we're anxious to see how that rolls out. We think it's going to be successful as well and be very supportive to families, foster parents. Excuse me. Referrals are in this program, all of our referrals are generated by CYF caseworkers. Of course, the court program, we can kind of generate our own referrals as we support families through that process. And so that's the CYF program. The Fathers program we're really excited about. This is a program that we just started. We're about a year into it, a little more. And we engage fathers from all different areas, and if you look down below where it says referrals, you know, fathers are being referred to us from the faith-based community, in fathers that are incarcerated in halfway houses, juvenile justice. Providers of mental health service are sending us referrals. We're getting them from the courts. We can do interagency referrals. So if one of our other programs has a father who could use the support of a father support partner, they can refer through the agency. And of course, word of mouth. The contract we had said that we would engage 60 fathers in 2 years, and in the first year we engaged 100. So it's really, really doing well, and we see dads really, excuse me, dads really stepping up to the plate. Excuse me, I have a tickle in my throat today, of course. And then I want to talk a little bit about the referral process. So some of our referrals, like I mentioned, are self-referrals, and that's generated a lot from the chat line. But word of mouth is, of course, another referral process that seems to be pretty effective. But in most of our programs, we get provider agency referrals, and so that's case managers or other providers of mental health services or any of the child serving systems. We get them sometimes from schools. We get them from all different places that will refer families to us. And, you know, we get them from behavioral health, juvenile justice, education, just all those child-serving systems. Other organizations that we get referrals from are faith-based organizations, the community, the jail, and halfway houses. And then, of course, again, our interagency referrals that we use. And the interagency referrals are kind of interesting because, especially with our CYF families, when CYF closes with a family that we have to close the case in CYF, in our CYF program. But what we do many times is if the family still wants support, we'll transfer that family from the CYF program to the Allegheny County Community Program, and they can still continue to get one-on-one support. So really, with the way things are set up for us, if a family wants support, there's always a way for us to manage that. And we also feel like families never have to completely, like if they graduate from a program, they're never completely not connected to AFN, because they can still go to our support groups, come to our functions, and things like that. So if a family wants to stay connected, they can. So family support partners, that's what we call our folks that do all the hard work. Family support partners are parents or caregivers who have raised or are raising a child with a mental health or emotional need. They are hired to share lived experience by telling their story when appropriate to families they support. They do so much. It was hard for me to just, you know, write everything down that they do, but they're so resourceful. They are peers, and therefore they're non-threatening to families. So I think that's sometimes why we get referrals from case managers who say, we need your help to connect with this family. So engagement is one of the things that we do really, really well. AFN also operates by a philosophy of do for, do with, and cheer on as parents and caregivers grow in self-efficacy. So one of the things as an organization we decided is that we certainly didn't want to enable people. We want families to learn, be educated, understand how to navigate systems and all of that. So we really operate by this philosophy, and it really works for parents. And then credentialing and certification. So we do all these certifications and credentialing, high-fidelity wraparound credentialing we receive from the Youth and Family Training Institute here in Pittsburgh. And then we have another credentialing that we do called Strength-Based Family Workers Credentialing, and that's actually a curriculum that DHS, our Department of Human Services here, in partnership with Temple University, put together. It's really a great family workers credentialing. And then Parent Support Providers certification through the National Federation of Families for Children's Mental Health. We have, I think right now we have 5 of our family support partners credentialed with that, but by June, all of our family support partners will be credentialed. We got a grant that's going to pay for that, so we're really excited about that. Some staff are certified to administer child adolescent needs assessments, so some of our staff have been trained and certified to do part of the CAMS assessment. Staff receive a wide range of training every year from us. We really are big on keeping our staff trained well. We think it's very important, and some of the trainings we repeat yearly because they're trainings that maybe family support struggle with more, like boundaries and those kinds of things. So we want to make sure our staff are given real quality service to the families. Family support partners, this is continued support provided. So here's just some things. There's so much AFN family support partners do. Of course, we do the chat line support. We do one-on-one face-to-face support in home or community, depending on what the parent wants. As part of a team supporting a family, so we work with other providers as part of a team. We go to court with families, family court, CYF, juvenile justice, and magistrate court for truancy. We do family support groups. In our family support groups, though, the goal is always to have a lead parent be raised up to take over the support group so that we are not the facilitators, but they are. Individual education plans, so IEP, we support families with IEPs in the school, and they do events, trainings, conferences, and activities, and many other casual encounters. So there's just so much that they do. Funding sources. This is always a challenge for family-run organizations, and most of our funding, as you can see, comes through the Department of Human Services in Allegheny County, 70% of it. 39% is through mental health-based funding, and 31% of it is through CYF, or Children, Youth, and Families. And then our JPT program that I had talked to you about, the High Fidelity Wraparound Program, is funded through Community Care Behavioral Health Organization, which is our Medicaid provider. However, it is program funding, and it's not Medicaid fee-for-service. Excuse me. And we get about 2% foundation funding currently. I've listed a little bit of that there. And then we have not been really good at getting private donations, and so we're going to work on that, but we get about 1% private donations. Excuse me, I had to take a drink. Okay. So our evaluation and outcome process. So organization-wide, we do what we call our Hope and Growth Pyramid. We have created a pyramid of life domains, and the family support partners do this with all of our families, and it's we find it to be a really good tool with families because the family colors it. If it's red, the family needs a lot of support in that area. If they color in a particular triangle in yellow, it means they they still need a little support in that area, but if it's green, they feel they can independently accomplish that skill. So it's a very visual way for families to see, like where they're at when we start with them, 6 months later when we do it again, where they've improved, and it's really nice. The families actually enjoy doing it. And then along with that, we have an outcome survey that's just it's written questions that they answer, but again, they respond in the same kind of visual color process. And then we do surveys, a lot of surveys that are project specific. So like for our court program and our fathers program that are fairly new, we create surveys that are driven by the logic models for those programs. And then collaboration evaluations, we work with other organizations that we're doing programs with, like in High Fidelity Wraparound. We do the WIFI, Child Adolescent Needs Assessments, the CAN, and the Youth and Family Training Institute that we work with right now started a new form that we're going to be doing as an evaluation, and they're just calling it chart form, but I think we might come up with a better name than that. The other thing that we do is a quality assurance, and that's our satisfaction survey. And what we do is we have a volunteer who comes in and calls families and asks them 10 questions about the service they're receiving from Allegheny Family Network. And so this is a tool that we use to ensure quality support is being provided to all the families that we serve. And that's it for me.
Thanks, Ruth. I really appreciate it. Now we're going to hear from Darren Harris from Louisiana.
All right. Thank you so much, Melissa, and thank you, Ruth, of course, for that powerful presentation. One of the things that I hear many parallels, and even though we're across the nation in so many different places, it's so wonderful to hear how there are so many similarities, just like similar life experience, which so many of our families have as they're participating in this process all across the nation. And so in addition to that, what I want to say is thank you, of course, for giving me an opportunity, to Fredla for offering us this opportunity, because one of the things that we realized as we began doing this work, we've been doing it for about 2 years as a family support organization in the state of Louisiana, building national partnerships, and having those partnerships have made this journey so much easier. And of course, attending things like the Georgetown University Training Institute, where we had a great leadership camp for directors and emerging leaders of family and youth-run organizations. And of course, Fredla had a huge part of that. Thank you, Melissa Pearson, and of course, Jane, for all the great work there, and all the board members. So with that said, my name is Darren Harris. I'm the Executive Director of the Louisiana Statewide Family Support Organization, and our organization is called Ekaya Youth Project. So as you can tell, youth is our primary focus and has been. We started about 2007 as a 501c3 nonprofit in the greater New Orleans area, really focusing on youth who are homeless, those who are at risk of out-of-home placement. And we've done a lot of work as it relates to that. So I'll just, briefly give you a little bit of that because I think it is important to talk about that as we get into our journey as a statewide support organization. And so in the beginning of 2007, by the way, Ekaya is a Zulu term which means home, where people can bring shared values, shared ideas. We're all welcomed at the table, no matter who you are or where. It's really important to us to build a sense of community. And so 2007, we began this work with young people and really recognizing that youth voice, youth choice is a must. Whenever developing programs, we have to have those young people at the table at all times. Because, they know best what works for them. And so we really hone in on the thought of youth voice and family voice, family choice, always keeping that at the center of everything we do. Long story short, in 2011, we actually we received a grant from HUD, which is a federal agency, to focus on youth who were unsheltered, transition-age youth who were unsheltered, ages 18 to 25, and these individuals who they were in places not meant for human habitation, i.e. the parks. They were in abandoned buildings and cars, all in the greater New Orleans area. And so we were able to take part of this pilot program and to get some very valuable information for HUD, as they're used to just housing people, but they realized when it came to young people, they needed to, of course, also focus on case management and intensive case management. And so in that process of doing that, we learned a lot of valuable lessons. Number one, we learned that 100% of those youth who were homeless and unsheltered had a mental health diagnosis. We also learned that 86% of them had aged out of foster care. And we also learned that many of those young people didn't have the basic life skills to maintain the homes that we were putting them in. So many things happened in that time frame, but we learned some valuable lessons. And after that pilot grant was over, I began to feverishly identify and look for ways that we could sustain that work beyond that pilot grant. And that's where I ran into or was informed of the Louisiana Behavioral Health Partnership. Now, the Louisiana Behavioral Health Partnership is a partnership between many different entities in Louisiana, child-serving entities like the Office of Juvenile Justice, obviously, and then you have Department of Education, and you also have the Office of Behavioral Health. So all of these state entities, child-serving entities, they realized that they were serving a lot of the same youth, and it wasn't the most cost-effective way to do it. And so they formed the Louisiana Behavioral Health Partnership, where each one of them would, of course, put into, if you will, a pot, right? And they would serve those youth who had imminent risk of out-of-home placement. And that was the idea, that we would share costs, and then we would, of course, reduce costs. And the idea was to create a program utilizing the coordinated system of care, the wraparound process, and a family support organization that would keep youth who are at imminent risk of out-of-home placement in the homes, out of institutions, out of the hospitals. How we started this journey. And as we were waiting to get credentialed and contracted to Magellan, because we have what we call a statewide management organization. Some of you may know it as a care management organization, where the CMOs, they are responsible for coordinating care for the state. It's basically outsourcing that process. And so in Louisiana, it's Magellan Health Services. And so as we were going through their credentialing contracting process, there was what we call an RFI, which is basically an RFP, request for proposal, and we wrote for it, and we became Louisiana's first statewide family support organization. And in doing that, it hasn't been an easy journey because we've had several different challenges. So I thought it was important to outline that part of it first as we move forward, because even though today we're experiencing an enormous amount of growth and success, but there are many challenges that came along with it, and something that many of the family support organizations may run into if you're partnering with other organizations, whether you're professionals. Some of those challenges were just the difference in terms of how peers are looked at, right? And so peers in some arenas may have a challenge working in the professional arena. And one of the things I tell my team members all the time is that no matter what, you are a professional, right? Similar life experience is what makes this work. And as we look at our current program model, you'll see, some numbers here. These numbers haven't always been there. Part of the challenge, of course, as we became the statewide family support organization, there's different things that, we had to consider, is identify folk who were ready to share a story, ready to, participate in this process, because this is something that Louisiana hadn't done before, and so it was rather new, the concept of utilizing peers, at least for mental health, behavioral health for children. Now, there have been adult programs of substance abuse, and those models work really well, but when it comes to our young people, it was a little bit different. And so the idea here was to develop this model, a statewide model, which was very aggressive, very ambitious by the state of Louisiana, and I applaud them on it because from what I understand, it had been done on county levels, but never one organization taking on this massive project of identifying, first of all, individuals that have similar life experience, and not just parents, but also youth. That's key. Because what we believe at Ekaya Youth Project is that when the whole family, when the family, the whole family becomes whole, then the whole family becomes whole. So it's really a process of supporting every individual in that household and making sure that they have the resources, knowledge, skills, and abilities to be successful. Of course, we do that through the coordinated system of care as well as through the wraparound process, which has been really effective for us. So currently right now, as you're looking at the screen, we're serving probably close to today 1,500 youth and their families. That means they're receiving either youth and support services, youth services. We also do independent living skills building. We also have a traditional mental health program, and because we really wanted to become a one-stop shop, we started as a state family support organization. As we begin to expand, we realized that our families, as they were being discharged, if you will, out of the coordinated system of care, which is for higher level needs youth, they needed to be connected. There had to be a continuum. And so one of the things that I thought was very important was to make sure that we were able to answer that call, because in many parts of the state of Louisiana, which many are rural, there wasn't this continuum. And so we started our traditional mental health services to expand that. And so that would include crisis intervention, what we call community psychiatric support and treatment, as well as the traditional mental health rehab model. And so we've expanded as it relates to that. In addition to that, we also have a new program which is called YOR, Y-O-R, which is the Youth Occupational Readiness Program. And so all of these programs are really important to us because, we want to make sure that, we're doing our part. We're being a responsible family support organization and supporting our youth and families. So currently right now, in terms of parent support, it's about 138, at least when I put this presentation together, and we're constantly hiring and identifying for parent support. These are parents who have similar life experience, and they've been there, they've done that, they've walked the journey. They've had to sit in the individual education planning meetings and listening to individuals who are speaking over their heads. They've had to, consult with a psychiatrist and had to figure out, do I put my child on this medication? But, when I put my child on this medication, my child, responds differently. And, so we pair them up. We partner them up with parents who have that similar life experience. In addition to that, one of the great things that Louisiana has added is a youth support component, which I'm very excited about, because this requires, of course, that youth to self-identify as one who has received mental or behavioral services in the past or currently still receiving those services, to help that young person, to help the youth to navigate the system. And that's really key to us to ensure that they're able to do that. And so having that youth support, as you can tell right now, it's about 178 youth support, and this is statewide. And so it's a fairly large state. And so this is it's broken down in what we call regions. So we have 9 regions. And then, of course, we have independent living skills building, which we have about 20. And so we're what we call life coaches. And we're building that program through another national partnership, which I'm excited always. In fact, I'm in California right now with Story Behavioral Health and Dr. Rusty, who created the TIP model, which is Transition to Independence Process Model. And we're here with them and learning more so that we can help you transition successfully. And then I talked a little bit about the wraparound process, and many of you are familiar with the high fidelity wraparound, and we heard Ruth talk about it, so I won't get too much into that, but that's one of the models that we use. We also use another model that is really good because it focuses on the underlying needs of those big behaviors with the functional behavioral approach. It's a great model, and all of these are trained through the state. The state sponsors these. And then we use a transition to independence model, and then so that's an evidence-supported model that we use as well. And then one of the other things that I thought was really key for us as we talk about things like confidentiality, HIPAA, boundaries, was to identify a national company with a web-based training. And so the name of the company that we've partnered with is called Relias, and Relias has multiple trainings that support our youth and support our parents as they do the work, and it's all online, and so it makes it very convenient And the reason why that's important to us as we provide these home and community-based services, because I understood that, it would be important for us as a responsible organization to pour as many of our resources into people and not property. And so we don't necessarily have bricks and mortar across the state. Our services are home and community based. So we have a centralized office which is located in New Orleans, Louisiana, where all of our HR, happens, all of the administrative function happen, quality assurance, quality improvement, billing is there, our billing department is there. Everything is housed in our centralized office, and our team, because we believe in investing in our team members across the state, we don't necessarily have bricks and mortar. We believe in investing in people and not property. And so as we began doing this work and we utilize a fee-for-service, because we are 100% Medicaid funded, and I'll talk about that a little later, but it was important to me to have and to give them the tools, the resources that they needed to be successful. And so that partnership with Reliance has been really, really effective for us. In terms of the certification that we have in Louisiana, the Louisiana Office of Behavioral Health and our SMO, which is our statewide management organization, Magellan Health Services in Louisiana, they're all responsible, and they've taken on the responsibility to ensure that we have the appropriate certifications. And so there's several different things that Louisiana has included, and then there's certain things that we are adding, which is really important to me as it relates to certification. And so we're building a partnership right now, of course, with the National Federation. That's important, that certification, which is awesome. That also, once again, back to STARS Behavioral Health with their TIP model, and there's some other creative things that STARS Behavioral Health also offers that really supports the young person and the young people. And then there's a host of online certifications that we have to go through that all professionals across the state also have to go through. And so it's a great way. Web-based has been the most effective and most cost-effective way for us to do this. And, there's a lot of training that happens, through the wraparound and, of course, functional behavioral and some other creative trainings that we have instituted within our organization, which we believe that's important. So ongoing continuing education is really important to us, identifying, of course, curricula that really support youth families. So I think, and moving and talking a little bit more about certification, I think it's important here to talk about accreditation. For us, we are going through the process through accreditation through CARF, C-A-R-F accreditation. This is an international accreditation. They don't have a specific survey or peer or family support organizations, but there is a component in one of the behavioral health standards. And so we're going to be going through that accreditation. Accreditation, once again, is because we have now embraced this one-stop shop philosophy. So we've gone from being a family support organization to identify other needs, other opportunities that could assist our youth and families. And so that's a part of the accreditation process. We offer, of course, those other services. In addition to that, cross-agency collaboration is so important. Working alongside, of course, with partners in the community, i.e. the wraparound organizations, and there are 9 different wraparounds in Louisiana, or organizations the way they're set up, but we're one statewide family support organization, so it's constant, communication, collaboration, coordination. These things are so important, and that's what's made our program model effective as we move forward to support, once again, youth and families. I won't spend a lot of time on the referral process. Down and dirty, it is really, really easy because we have a statewide management organization. It's a really simple process, and anyone actually can call in and make a referral in the state of Louisiana to the coordinated system of care. And so as we talk a little bit more about, that particular referral process, this management organization, which is Magellan Health Services, there's a 1-800 that individuals can call, and through collaborations, of course, with the Louisiana Behavioral Health Partnership, we'll get referrals from the Department of Education, from the Office of Juvenile Justice, from the Office of Behavioral Health, from Child and Family DCS, as we call it in Louisiana. Referrals come from multiple different ways, but in addition to that, we also get referrals from the courts, we get referrals from school, we get referrals from psychiatric hospitals, from pediatricians, we get referrals from parents. And so there are many different ways in which we receive those referrals, but every referral goes straight through to Magellan, Louisiana. Once that call is made, there's what we call a brief CANS assessment that is done and conducted over the phone. Youth is who's eligible for the coordinated system of care for family support services, which will include, of course, youth support, family support, peer support, youth peer support. Then Magellan will make what we call this referral, and they will send out presumptive referrals to the wraparound agencies within those regions, and then, of course, to the statewide family support organization. And what they're looking for when they do that brief CANS, when that referral is made to that centralized location at Magellan with a single point of entry process, they are identifying, number one, is used, will they be deemed eligible clinically, right? And that's through the CANS assessment. And then also we look for financial eligibility through Medicaid, because these services, once again, are 100% funded through Medicaid. And so they ask, questions related to the youth as age, do they have Medicaid, mental health history, substance abuse history, medication if they're on any medical history, those type of things. And were they in any challenging situations with child welfare, juvenile justice, or in school. So once they identify that, that presumptive referral then goes out to the family support organization. So we have a chart here that kind of, outlines it step by step, and I won't, go through this completely, but referral we make sure that we have a 1915C waiver, which is required for the Medicaid program. The CANS assessment, the freedom of choice, which is so important because families have the right to choose. Say that all the time, nothing about us without us, family choice, family voice. And then there's something called the plan of care. For those of you familiar with the round process, there's a plan of care, initial plan of care that's developed for the family, by the family, which is always important to us, that the family's voice, that this is, family-driven, youth-guided, those things that we're familiar with here in strength-based and utilize, data-driven, all these core principles and values that are part of coordinated system of care. And then, you'll see here, once that gets to the statewide family support organization, immediately goes to the appropriate region. That regional manager would then, of course, assign it to a parent support, youth support based upon what the family chooses at that time. And what we realize is that many of the families that come into the coordinated system of care, not immediately they say, I want this, or they don't even understand it. And one of the challenges, many parents have said, well, I don't need parent support, I'm a parent. And so we've had to come up with some very creative ways in engaging them to receiving these support services. So they may not necessarily accept it right then, but they will a little bit later. And then we just continue to work along with the wraparound facilitators. I won't go through this process here, but I wanted to make sure that you guys had this information, and this comes straight from our service definition manual here in Louisiana, from the Louisiana Behavioral Partnership Service Definition Manual, just so you can get an idea of what the parent-to-parent support looks like in Louisiana and what they're doing and how they're able to help families, of course, with their planning and assessing services, and also helping them to remove barriers, may show up from time to time. And in addition to that, also to just continue to support them and support different for every family, and that's what we hone in on, the individualized plans, which is really important. But what we really, really encourage is home and community-based, because that's where big behaviors happen, that's where families live. And so we want to meet them where they are as they are as it relates to that. Youth support, so that youth support or peer support is really important, because youth need someone that they can connect with, someone that they can share, different stories, and of course, we focus on that recovery. For youth, we say discovery, because many young people, as it relates to mental health, behavioral challenges, it's not really about recovery, but for them, it's more of discovery. And so we really hone in on that particular focus as we continue to help them to become successful, right, in their natural environments. And that's what's important, and that they identify where their natural supports, because we realize that our job and our role is not to be in their family or in their lives forever, but to help them to identify their own resources. And all of our services are face-to-face. That's really important to us, that we have face-to-face contact. We do groups for our young people as well, and sometimes we even have individuals that show up in the school environments. All right. So I'm almost like Ruth. I'm going to need some water in a minute. I'm trying to wrap this thing up, and hopefully I'm giving you some good, valuable information and just kind of giving you some highlights right now. And so in terms of our funding, once again, 100% funded through Medicaid right now for our family support services. We do have some other services that we have we have grants for, and then there's also fundraising. And so it's been unique in Louisiana. We're really appreciative of how we're able to utilize Medicaid funding, and as Melissa shared a little bit earlier, it does come with some challenges, but we've found ways to overcome those barriers and to meet Medicaid standards, and so that's been really helpful. It's a sustainable model, and it's been really working well for us in Louisiana, and so that's our funding in a nutshell. We always continue to, go after grants, and you can, of course, do some other creative things supporting youth and families. In terms of outcomes, and we have several different ways in which we get that information. There are all types of internal reports that, as you can imagine, being a part of the state system, and then, of course, the statewide management organization. There's all types of internal reports. We look at enrollment, services rendered, and then the billing. Data-driven is one of those, of course, values of the coordinated system of care. And so we have to continue to show that this works, and it's really important. Another way, we're not just looking at the quantitative, but we're looking at the qualitative data. That's important. And we do that through surveys, which is one of our CARF standards, right? CARF requires us through that accreditation, and, it's a part of our policies and procedures that we continue to do these surveys and continue to ask the questions, because there's always room for improvement. And so we're asking questions of the youth, the family, team members, which is important. Those are the individuals doing work on a good. And then, of course, our valuable stakeholders that help support youth and families as well. And then we also, because we're a statewide family support organization, it was important to me to be able to manage the program well. And so we couldn't use a traditional way of, writing progress notes. We had to go into a much more sophisticated system. So we use an electronic medical record, and I have a little graph at the bottom. You can kind of see some of those things that we measure, but we use a company called Once Logics, and it's a great company, and they have a program called ShareNote. ShareNote has been amazing. I'm able to manage in real time. It is cost effective, it's efficient. Those progress notes, I can read them in anywhere. We have about close to 400 team members with all of our programs combined. And so as you can imagine, it's a lot to manage from a statewide perspective when you have 64 parishes, which you would know 64 counties. And so it's a daunting task, but having an electronic medical record ensures that, we are compliant. It ensures that we're able to measure, because, we can't manage what we do not measure. So these things are very important to us. And then last but not least, there's state and, of course, our SMO, our Magellan Health Services reporting that we're required to do. And sometimes those reports, even though we have database that we use, sometimes there are other external reports that we've been asked to give. And so we, because we're great partners, we just comply, and we make sure that we get the information to them in a timely manner, because we do understand that being data-driven and understanding that, the data will make the difference, and then, the doing must match the data, and the data will always match the dollars. I have all little sayings to help people, but at the end of the day, it's about making a difference, and we know that. And if we're going to continue as a statewide family support organization making a difference, so that we have that it's working. And so that's pretty much it. Too bad. I'm going to go ahead and wrap it up.
Okay. Thank you so much, Darren, for that information about the wonderful work you're doing in Louisiana. And now we're going to hear from Paul, who comes from the Alaska Youth and Family Network. Go ahead, Paul.
I don't know how I'm going to top Ruth and Darren for sure. I was just thinking one of the reasons that I like being involved here with Fredla and with the family-run movement across the country is I get to learn so much. And Ruth and Darren showed me a lot of possibilities. In Alaska, we're not in the same place that much of the country is. We're a little bit behind you. Our budgets this year in our state has just been determined to be unsustainable. And we have a new administration who is finally looking at Medicaid expansion, and that's hopeful for our organization. It's offering us some hope for expansion and inclusion in a broader system. Our system is very much medical model. Most of our children who experience severe emotional disturbance and young adults who are diagnosed with a mental illness in Alaska receive most of their treatments out of home and away from their communities. So home and community-based services here are few and far between. And so we're really hopeful, and to hear Ruth and Darren talk about the things that are happening in their communities is really exciting for me. So I'm Paul Cornells. I am the Executive Director of Alaska Youth and Family Network. I've been involved with the organization since about 2005. I've been employed here since 2008, and I've been the Executive Director for 4 years this past January. Alaska Youth and Family Network is a statewide family-run nonprofit behavioral health and advocacy organization dedicated to helping families raising a child, youth, or young adult who is experiencing a mental illness, emotional, behavioral distress, and or substance use issues to navigate Alaska's systems of care to achieve wellness and recovery for their loved ones, themselves, and their families. We emphasize systems instead of system of care in our mission statement because we don't have a system of care. We have many systems that our families have to travel through and our children and youth have to travel through to get the care that they need. Oftentimes they still work at odds with one another. They're not very well coordinated, and they can be very daunting. So what we do, we have a staff here of just 13 for the entire state. We hire parents, youth, and peers with a wide variety of professional experience. Our staff is hired for their lived experience, and then we look at their professional and academic experience as a way to enhance that. So our staff here right now, we have a marriage and family therapist on staff. We have 3 parents or youth who are certified chemical dependency counselors. Our average staff at AYFN has been here for 3 years, and they have an average of 11 years providing behavioral health or social services in other capacities. That isn't to say that we don't hire people who don't have that professional or academic experience. We certainly do. Right now, I've got 3 of the best people that work here have no formal professional or academic training at all. One of the reasons that we changed the model is when I came on in 2010 as the executive director, the state said, been funding you long enough, we're going to pull your funding, you have to figure out how to switch to Medicaid. Our state Medicaid has a provision for providing peer-to-peer support and a vague idea written into it about what family-to-family support should look like. But when we looked at it as an organization, that option as a way to sustain ourselves and continue with the work using a model close to what we use now, we figured out that we weren't going to be able to keep our doors open. At best, under the model, we could replace maybe 50% of the funding that we receive through Medicaid, and the rest would be a loss. So we worked toward that end. We professionalized our staff. Like Darren, we began to emphasize data collection and documentation, being able to tell the story of the work that we're doing in a way that's meaningful to the people that fund us and to our community is really important. And we had to look for a staff who had a passion for the family and the youth work, who also understood the importance of documenting and treatment planning and collecting that data. And I think we're there now. I love our staff. They go the extra mile. They're caring. They're professional. They're well received in the community. They're well respected. So what we do, we use family peer-to-peer support model. And in Alaska, we are the only exclusively home and community-based service provider, behavioral health service provider in the entire state. Most of the other child and family serving organizations in our public system, their main line of business is some form of out-of-home care, therapeutic foster care, level 4 and 5 residential services. Much of that is driven by the rural nature and the fragmented nature of our communities. 40% of our population don't live where they can drive to receive care, and they live in small communities, 200, 300, 400 people. So there isn't a lot of capacity when you have a family member that's in crisis. We serve the entire family here. We serve them the entirety of their need. We help them find employment and housing and medical care and all of those things that a family needs to be healthy and whole and self-sufficient. We do a ton of advocacy. The bulk of our work in our system is advocacy, mostly driven by the fact that our model in our state is medically oriented, and it is not family or user friendly. Very much driven by the provider. We provide a really wide array of services. A lot of the language that I use in describing our services is driven by the system that we work in, although it's very much exactly like the services that Ruth and Darren described in their communities. Right now, we're training our staff to translate a lot, and most of the translation that we do is for the provider community. When we talk about family-driven and youth-driven and home and community-based supports, they have very vague ideas, and they're resistant to the idea that a family should be able to not only participate in the planning of their care, but actually drive that care. So we use words like case management and care coordination and family preservation when we're describing our services. So last fiscal year, which is our state fiscal year 14, we served 692 families with our staff, 755 parents and caregivers. We serve the identified caregiver. Whoever walks in our door and says, I have a child that I need to figure out how to take care of due to my child's mental health needs or my own mental health needs. So, and that's something that makes us, I think, unique among family runs, is that we target parents who are experiencing very significant, sometimes, struggles with mental illness and substance use, and trying to figure out how to keep their children at home and successfully parent them so they don't lose them to our child welfare system. So we have this overlap. About 70% of our parents or so, they're walking through our doors and they have significant needs themselves and significant struggle themselves. And actually last year, a greater percentage of the parents that we served were struggling with a mental illness or a substance use issue than our parents were, or than our youth were. So the people that we serve, the families that we serve, come from just about everywhere across our state. Last year we had about 80 different referral sources, everywhere from, the usual schools, juvenile justice, child welfare, to just about everywhere. Real estate agents we had last year when I was looking over our referral sources. We had lots of teachers. Our school district right now is discouraging referral to special education assessment. So teachers are identifying students in their classrooms and then referring them to us and their families for advocacy and support in order to get those services. Generally a budgetary issue in the districts that we deal with. 50% of our referrals are word of mouth. They're parent-to-parent, youth-to-youth referrals, and 61% of the families that we served last year had child welfare involvement. So they're significantly at risk. Their children have been removed or are at risk of being removed from their homes. So at AYFN we have an open access, open door model. And so essentially if you contact us, if you walk in our door and say, I need help with my family, we're going to help you. So we are able to do that because our funding is flexible. And we have a unique stream of funding from a funder here in Alaska, the Alaska Mental Health Trust Authority, that funds us to serve all of what they call trust beneficiaries. So that's anybody that experiences a substance use, mental health issue, they're homeless, or they suffer from dementia or a brain injury. So we can serve just about anybody that comes through our doors because of the flexibility of that funding, and we do. Once you walk through our door asking for help, if we're not qualified or capable of helping you, we will stick with you until we find somebody that is. We use an unconditional care model modeled on Seneca, which is a residential program out of California that serves really challenging youth and their families. It's a model that focuses on building relationship and engagement to increase the feelings of hope and possibility that the people that we work with are capable of experiencing. The folks that we work with here, to give you an idea, 90% of them last year were at or below the poverty level, and 95% were single-parent homes. So we have a significant level of need that are walking through our doors, and they've not had largely positive experiences in other places in the community. So we work really hard to change that. We walk with them and help them build those relationships. We provide a judgment-free environment for the people that we serve. It's strengths-based. We use a psychiatric rehab wraparound approach to the behavioral health services and the family preservation services that we provide. And the cornerstone, the message that we're trying to send to our families is one of hope and personal responsibility. Things can change, and it's up to you to change them. We're a tool. AYFN, the people that work here, are tools for our families and our youth to use in their journey to change their lives. Because of the system that we work in, the amount of skepticism that we receive sometimes because of the family model and the preference for hiring people with lived experience over professional or academic credentials, we receive, our staff receive a lot of training, 300 to 400 hours of training a year. In-house, we train to the standards of the National Association of Peer Specialists. We use, just like Darren, we're very involved in tips through STARS Behavioral Health here in Alaska. It's a model that the state has embraced, and it is a very effective strength-based model for engaging youth and their parents. There are a lot of tools in there that work across populations. They receive a lot of trauma-informed hours and hours and hours of trauma-informed care. We're very aware of the ACEs, Adverse Childhood Experiences Scale, and the effects that those have on people. We've partnered with child welfare. My staff all go through the same new hire orientation and social welfare, the child welfare training that the staff that our State Department of Office of Children's Services hires. They receive peer navigation systems navigation training. Like Darren, we use Elias for a lot of our training. And I think the primary success of our model is that it is very support focused. Our staff receive tons of support here. They receive about 2 hours a week of individual case-based review. We do group case-based review, and they have access to our clinician 24/7 when they need support. Our intake process, we included that. It is much like Darren's. It's very, in Ruth, it's very simple. Walk through the door, and somebody will sit you down, talk to you about your situation, and begin filling out the paperwork for you. Most of the people that come here never actually fill anything out. So the parent-to-parent support slide that I included was just a definition of and a breakdown of the services so that you guys could see them and how they're defined here and how they're defined within our community and our system of care. We provide a lot of connection to resources, just like everybody else. They're few and far between, especially if you're not connected with a residential program. So we're bringing more and more of those in-house, or we're contracting for those services so that the families that we serve have access to them. We teach, the model that we use for advocacy and support here is teaching support. So we teach the youth and we teach the parents that come to us the skills that they need to advocate for themselves. Very rarely do my staff directly intervene on behalf of a parent or a youth. They provide support, they provide coaching, they provide training, they give them the skills so that they can speak to their providers or their caseworkers or whoever on their own and learn to meet their own needs. So our funding, we have a broad array of funding here. Probably about 70% on any given day is grant funding. The rest of it is fee-for-service and contracts. Most of our contracts are with our child welfare system. We provide probably $100 a month, probably about $1,200 a year of transition support for pre-adoptive placement. We believe that outcomes in our system, especially to prove our model and the effectiveness of what we're doing, we collect a lot of data here. We use a family empowerment scale, 2 tools that our state has adopted so that we compare across providers. They use the Child and Adolescent Service Intensity Instrument and the Early Childhood Instrument, and we use the North Carolina Assessment Scale Reunification Subscale to show the effectiveness of our services to prove those to child welfare. The success that we've achieved last year, we had fewer than 1% of the children and youth that came to us move to a higher level of care after they became engaged with AYFN. And I think that's the thing that I'm most proud of, is that our staff is keeping children at home with their families. They're keeping their youth at home and connected to their communities and their schools and their families, and they're doing that in a way that is safe and helping those families become independent and self-sufficient. As far as our child welfare involvement goes, when AYFN staff are involved with a family that has had a child removed from their home, the reunification time is about half of that when compared to a family that doesn't have involvement with an AYFN peer navigator. And the repeat maltreatment rate for the families that we serve is almost zero. Because of the open access model that we use, families are always, once you're being served here, you can come back at any time and we will serve you, no questions asked. And in general, in our child welfare system, our repeat maltreatment rate is twice the national average. So those are things that we're all very proud of here. And that's all I have. So, thank you.
Well, thank you, Ruth and Darren and Paul, for sharing each of your models that you guys are operating in Louisiana, Pennsylvania, and Alaska. I think that you guys have really developed some wonderful programming. Now, for the last few minutes, I want to see if we have any questions for any of the presenters regarding any of the information about their models that people on the phone might have. Meredith, do we have the opportunity to open the lines for questions, or will they need to type those in the chat box? Okay, you can type the questions in the chat box right now, and we will handle them that way. And the phones are now unmuted as well. So if people have questions they want to ask live, we can take that as well. We have a question from Audra that says, are we going to have access to the PowerPoint presented? Yes, you will. We will post the PowerPoint slides as well as a link to a recording of this presentation. Both it will be on the TA network as well as Fredla's website.
I mean, that was what she said. Is that basically what it is for?
Can you ask that question again? I didn't hear that. Can you speak a little louder?
Oh, no, I just said that.
Anybody else have a question? We also have, if you look down towards the bottom, there's a couple of resource documents that we included for you. One is the joint bulletin from CMS and SAMHSA that I referenced at the beginning of the presentation. And the other is a survey that the Center for Healthcare Strategies did a couple years ago, looking across the country at different parent-to-parent support models, looking at what kind of funding they were using, rates of reimbursement through Medicaid, and those kinds of things. So those are also available to be downloaded.
And then you know every picture of that thing is going to be extra crispy. So I ain't going to be able to really find that.
Anybody else have a question? I think we've got one question coming in the chat box.
Yeah, and I was like, whatever, Mr. Devlin.
Okay, we will wait to see what the question is in the chat box, and I'll read it for folks.
What did they do now?
The question is, just wanted to clarify that Allegheny stated they received 70% from DHR. Ruth, do you want to respond to that?
Well, that's DHS, the Department of Human Services, and those were mental health-based dollars, and children, youth, and family dollars from the county.
They still a child.
Thank you, Ruth. We've got another question coming in the chat box.
You talking about Jerry?
Any other questions from folks on the phone? All right. Hey, I think we've answered all of our questions. I want to thank everybody who attended the webinar today, as well as our 3 presenters for sharing all of that wonderful information. And we will get the PowerPoint slides and the recording out to everyone shortly.